So just to review, blood pressure equals cardiac output times systemic vascular resistance. Cardiac output is composed of stroke volume as well as heart rate. Now, stroke volume, as you may recall, is the volume the heart pumps out every time it contracts. Stroke volume is dependent on contractility, right? If you have more contractility, the more it's going to pump out with every time it gets a stroke. Afterload, the easier it is for the heart to pump, the more it will pump out. And then preload, that's the effect of preload on stroke volume depends on where it is on the Starling curve. If it's on the steep part of the curve, then as you increase the preload, you will get more stroke volume. However, if you are on the flat part of the curve, you may not get any changes in stroke volume, and in fact, if you're on the downside of the curve, you may actually decrease your stroke volume. And then preload is dependent on volume as well as the right ventricle. The more volume you give, and again, like I just said, the more preload and you are on the steep part of the curve, the more stroke volume you're going to push out. But it also depends on the right ventricle, right? Because the heart works in series. So if the right ventricle fills the left ventricle, but the right ventricle doesn't work, so you can increase the volume to infinity, and you might actually just make things worse because it's not being pumped from the right to the left, and in fact, overdistension of the right ventricle may push the septum towards the left and inhibit left ventricular function. So how does the smooth muscle contract? That is, what are the triggers for it? Well, you can have a myogenic trigger. So what does that mean? So the vasculature has a ability to determine how stretched it is. So when it overstretches, it creates a autoregulation mechanism that tries to get back to where it was before. And you can imagine that, well, this is essentially the mechanism as to how we have autoregulation to maintain flow constant. Okay? Then you have electrical, which is simply depolarization, where you have L-type calcium channels on the plasma membrane of these smooth muscle cells that essentially, when you have calcium influx, causes constriction. And then you have chemical signals, such as when you give epinephrine or norepinephrine, which again leads to a signal cascade leading to eventually smooth muscle cell contraction. So what are these vascular resistance and inotropy molecules? Well, the first four molecules here, alpha 1, or not molecules, but receptors, are alpha 1, alpha 2, beta 1, and beta 2. These four receptors are part of the adrenergic system, and all four of them work via G protein coupled receptors. Then you have calcium as a signal, dopamine receptors, nitric oxide, angiotensin, and then you have others. Others are, for example, endothelin. We currently don't, that I know of, have endothelin agonists to improve blood pressure, but we do have endothelin antagonists, which is used in pulmonary hypertension to decrease the pulmonary vasculature's tone, and therefore decrease pulmonary hypertension.
Guys, thank you very much for watching. Make sure that you like this video if you like it. If you don't like it, then do unlike. Like this video, subscribe to the channel, and please share this channel with others as well.